Hello, good evening. Welcome to my Advances in the European Fertility Society. We are once again back here with another topic, and our special guest is with us already. As you can see, Dr. José Félix García España is with us from Vista Hermosa, located in Malaga. So the exact name is El Ángel, correct? Just correct me if I'm wrong, but I think that's the correct name of it, El Ángel, in Malaga. Is that right?
Yeah, that's right.
Perfect. Thank you so much. Dr. Garcia has been presenter during our events before, so I'm really happy to have you back. And today we are going to discuss a tough topic. I think this is always lots of questions are always brought to this kind of topics. We will talk about egg and embryo quality in women over 40. So we will start with the presentation on the topic, but your favorite part will start right after the presentation. So please remember to put the questions in the chat. I'm sure it's going to be a great session. We do receive lots of questions in this kind of topics, so I'm sure you have plenty of those. So please remember to put those in the chat, and we will definitely try our best to answer all of them. And remember, it's all being recorded and will be available on my VFNS's website as well. But I think that right now we can go ahead with our presentation. So we not to keep you waiting too long. And remember, you can type the questions in the chat during the presentation or afterwards as well. Okay? And let me know if you can see the presentation and if all is okay, and we can start. Can you see the presentation, Dr. Garcia?
Yeah, fine. Shall I? Shall I start?
Yeah, we can begin with the presentation.
Great. Okay, so good afternoon, good evening, depend. And well, I've been invited just to talk about this, about the aging, in fertility, the quality of the eggs and the embryo quality after the 40s, above when we are over 40 years of age. And then that is a problem that we face every single day. And then the main idea is that it decreased. One of the things that of this group of women present is that the ovarian reserve has decreased, and that's very common. Many of you that comes to the clinic, you can worry because you did an anti-Mullerian hormone, and doctor, my anti-Mullerian hormone is less than 1, etc. Well, we may talk in the later, or in your question, probably some of you will ask about that. And then that's very important in the way that if a woman more than 40 or more than that comes to the clinic, she's going to need an IVF, because if not, the ovarian reserve is not very important, because in the end, a woman with a large ovarian reserve, another one with a short ovarian reserve, they're going to ovulate one. But if we talk about IVF, that's very important, as we will see in a few minutes. And then the other, so those women present, or these women present, a short number of follicles and consequently eggs, and increasing aneuploidy, which means abnormal number of chromosomes. We know that a normal karyotype means that we have 46 chromosomes, 23 pairs. And then the egg should come with 23 chromosomes, and the spermatozoids with another 23. And both of them, when they become an embryo, they will lead to an embryo with 46. If the egg comes with not 23 chromosomes, but 22, 21, 24, then the numbers don't match. And then we have embryos with 47, 45, but not with the normal number of chromosomes, or with the normal number with a lack of a piece of chromosome one or the other. Then, so we have a short number of follicles available, and the quality of those eggs comes with abnormal chromosomes already. Then, what happened with the embryo quality? That if we are making embryos with bad eggs, then these embryos come also with aneuploidies, as we said, and it has the problem is that depend on the abnormality of these chromosomes. When we do a pgt-a, a biopsy of the embryos, sometimes we are informed that some embryos are chaotic. It means that they come with lots of abnormal chromosomes, and others just with one chromosome plus or less, I mean 45 or 47. Then, depending on that, reduced implantation potential is what it comes now. It means that if the embryo comes with a lot of abnormalities, maybe it's enabled even to implant. There are other reasons for the implantation, of course, but the progress of the embryo inside the uterus of the mom will stop sooner or later, depending on the chromosomal abnormality. It means that sometimes we have a negative pregnancy test, probably because the embryo couldn't even implant. Sometimes we have a positive pregnancy test with a beta HCG high, but then we never see the sac. Sometimes we see the sac, but we can't see the embryo. And sometimes then we see the embryo. This is a miscarriage of 7 weeks. And sometimes it reaches the end of the pregnancy because, for example, it's a Down syndrome or the syndrome, which are compatible with life. So it's all part of the same problem. Of course, we have to say that there is an individual variability. These are statistics, and then we have to trust that we have studied many women, and we see that this is a tendency, but there is always a trend, but there is always exception, and it's very typical when a woman 42, for example, or 43 comes, and we explain this problem. We say, well, we're going to help her, but she has to be conscious, aware of what are her possibility. But many times they say, well, I have my aunt had a baby when she was 44. Of course, it may happen, but probably there is one that was successful for 500 that they couldn't, and they were not saying that they had that problem. So this is something studied, but as we are going to demonstrate later, by studying many women and see that this is the problem. So in short, we say that the main problem that these women presents is a short number available to work with, but quality of eggs, mainly because you have to understand that women have like a box with eggs, and then you are as a woman consuming a number every month, and then in the end will rest very few and the worst. That's why the menopause come in women and not in men, because physiologically the testicle works as a factory that is producing spermatozoids with more defects and more problems and not the same quality and not the same number. But till the man dies, it will be able to produce spermatozoids, while the women then will face the menopause, which means that there are not more eggs available. And before that, from 40 onwards is when that is more evident. Right. So what is the strength of IVF? So as we said, the age and the number. Because the number is very important, because let's think that we have a woman who is going to have an IVF and she's 32 and has a very nice ovarian reserve. Let's say 14 follicles, 7 on each ovary. Then we know that statistically speaking, there is a 70 to 80% rate of obtaining eggs. Once we put the needle in the retrieval, the needle inside the ovary, and we aspirate, we expect to obtain 70 to 80%. As we said, statistically speaking, it means that probably she went to theater with 14 follicles, and then we have obtained 11 or 12. Then we go ahead with ICSI, with micro injection, and the following day, another 70 to 80% of those have fertilized. So she started with 14 follicles, then we obtained 11 eggs, and now we have 9 embryos, eggs that has fertilized. And then they will go to the incubator, and they know that there will be, you know that very well, quality A, B, C, A, B, B, C. And what I brought here is that we have to keep in mind that 31% of those embryos who have reached the day 3 will not reach the stage of the blastocyst stage. So probably that woman at 32 with an excellent prognosis, with a very good number of follicles, will have in the end 4 or 5 embryos, which is very good because she's going to have 4 or 5 tries transfer in the end to get pregnant. So if we think now, start thinking in a woman 41, 42, more than 40, where she's presenting a low anti-Mullerian hormone, we have checked that with an ultrasound, a vaginal ultrasound scan, and we have counted 3 follicles. No matter how much hormones we're going to give her, that only 3 follicles will grow. 3 follicles will put the needle in the retrieval day, and then let's keep our finger crossed in order to hope that at least we may have 1 embryo if we are lucky. And then we will see some figures here, some pictures that may illustrate what I'm saying. Look at this. This is just facing the problem at the number of eggs. These are eggs, oocytes. Then a woman less than 35, as you can see here, every 4 eggs, every 4 ovulations, if we are talking about a natural cycle, 1 will be able to give a good embryo, an euploid with normal chromosomes. It doesn't mean that it's going to give a pregnancy by sure, but it's a good embryo with high rate of probabilities. And then it goes down. You see these groups down in between 35 and 37. It's 5 ovulation, 5 eggs to find 1 good embryo, and so on. If we go with more than 42, that woman will need 20 ovulations. I mean, if she tries to get pregnant at home, and there are examples that of course, as we said, there are women that got pregnant, but every 20 months, she will have 1 ovulation that may give her a pregnancy. While at 20-something or 31, 32, every 4 months, she may obtain at home. I'm talking I'm not talking now about IVF, but just in a natural at home, in a natural ovulation. But let's think of what we said before. We are stimulating a woman more than 40, 41, 42, even 40, and then she doesn't have a very large ovarian reserve, and we may go for 3, 4, in the best cases, follicles, and then look at the statistics and what the chances are of finding in the end a euploid, a good embryo. Then in this one, this is one of the best studies that I think is being done in fertility. We are not talking now about eggs, but embryos. These are blastocysts, or represent blastocysts. Then the green one are euploid, the red one are aneuploid, with abnormal chromosomes, with normal chromosomes. And this is a study done in 2016 in Italy, where a large group of women of different ages, all of them who had an IVF, all embryos were taken to the blastocyst stage and had a pgt-a, a biopsy, and check which one were coming normal and which one with abnormal chromosomes. And you see how in this group of less than 35, 3 out of 5 blastocysts, statistically speaking, were euploid. That's why in the example I gave you before, 31, 32, with a large number of follicles, then in the end I said, well, in the end, she's going to have 4 blastocysts, 4 opportunities. Sooner or later should come one of these green one, which may lead to a normal pregnancy. That's why in this group of women, we have 75 to 80% chances of obtaining a pregnancy. I'm talking in a cumulative way, not by embryo, but a woman of this age in our clinic doing an IVF, she may have do an IVF in January, and maybe she will get pregnant in June with the 3rd embryo, but she has a 75 to 80% chances of obtaining the pregnancy. While if we go out the other side of the group, then we see more than 42 or 41, 42, they need 10 embryos, 2 out of 10 blastocysts, or more than 42, 1 out of 10 blastocysts will be euploid. We have to say that once we've done the biopsy, these green ones have 56% chances of giving a pregnancy, not because they are green, because they are euploid, they're going to be they're going to lead to a normal pregnancy, but they have very strong chances. They're very good embryos, right? So then if we think in a woman 42, for example, of this group, that she has an ovarian reserve that present 3 follicles, think what I said, that 70 to 80% in the retrieval to obtain eggs, another 70 to 80% to be fertilized. Then how many embryos will be able to be blastocysts? And then imagine that you put your hand in a box full of balls, 9 red and 1 green. Which are your possibilities of that embryo to be green, to be euploid? Very slim. That's why typically we said that more or less at 40, the rate, as we said, that less than 35 is a 70 to 80% chance of getting pregnant. At 40, it may go around 20, 41, 12%, 42, 6%, and more than 42, there are colleagues that they don't do IVF in more than 43 onwards because they think that it's not proper, it's not ethical. Well, it depends of anyone, and because of these individual variabilities, one have to see case by case and analyze and to inform. And in the end, it's just to inform the patients, and they will decide, but knowing what the truth is. And then here is, just to make things worse, this is the rate of miscarriages. Remember what we said about aneuploidy and what happened with failure of implantations or miscarriages because of the quality of the egg. The egg was coming with abnormal chromosomes, and then they lead to an abnormal embryos. So here, less than 34 years of age, nearly 15% rate of miscarriage. That is normal in human. We are not very fertile. We are not like other animals that they get pregnant immediately and with a very low rate of complications. Then 35, 39, 23%, 40 to 42, 41%, and more than 43 is a 70% that if that woman gets pregnant, have a positive pregnancy test, in a 70% of the cases, it will not reach the end of the pregnancy because it will have a miscarriage before. So what can we do about it? How to deal with this situation? That's the last thing to talk about, and then I open I'm just ready for your questions. So sometimes, and I said we have to tailor every case. We have to we cannot generalize and see case by case, but sometimes we may have the option to repeat cycles. So that woman is 40 or 41 and is presenting 4 follicles. I say, okay, doctor, I'm gonna stimulate myself once, and then we will see how many embryos I have in the end, but then I'm going to repeat it again in order to have more embryos. Well, that's good, above all, if we want to analyze them, because it's more economical. It may give us a better idea of the situation if we analyze not one embryo to see if it comes with normal chromosomes or not. Better if we may analyze 3 or 4. Of course, pgt-a is an option, because that woman may say, okay, doctor, yes, I know what my age is, the rate of Down syndrome and all the syndromes and the rate of miscarriage. I don't want to suffer. I want to try to avoid these situations. And if the embryo is not worth be transferred, I prefer that. So we make a biopsy of the embryo and said if we may have, in a very good cases, 2, 3 embryos in this group of age, and then maybe most of them are aneuploid, and then the woman is not happy, but at least they know that she's not going to have a transfer, because that transfer is not going to give us a pregnancy, and at least it's better to avoid the waiting for the beta ACG for the pregnancy test, or to have a miscarriage or the problems later. Another option is egg donation. At the moment that the woman choose that way, that path, then it's another girl, less than 35, who is going to give the eggs, and immediately she changes the group and she belongs to the group less than 35 with all the advantages. Of course, those embryos will have the genetics of the husband, if the husband is going to give the sperm, of course, and the donor genes. Then the mother, who is the receptor, will give what we call the epigenetics, which is that's another subject, but it will modify the expression of that genetic pattern. So it's not the same that the embryo, if it's carried by one woman, or the same embryo be during the pregnancy carried by another woman. And then what about the increasing ovarian reserve? That's very controversial. You know that platelets, the serum rich in platelets injected inside the ovaries. There are some clinics that are working very hard on that. In the last European Congress celebrated, they said that there has been nothing demonstrated that this is doing something, above all in this group of age. There has been published something that in young women with low ovarian reserve may increase something, but we're not talking about having 2 or 3 follicles and then suddenly, because of that, to find a dozen, 12 or 10 follicles. Not at all. Sometimes, and we have to keep in mind that every month the ovarian reserve is not static. It's not always the same. It may vary 25% up or down. So a woman that in January presents 3 follicles, in February may come with 4 or 2, and it will go around that number. And because of that, we need further studies to to be sure that this method to increase the ovarian reserve is worth doing it. So this is everything I wanted to tell you, and just to leave you time now. We have 40 minutes for any question that you want to tell me. I hope that I will answer correctly, and
Thank you so much
fulfill your expectations.
Definitely. Thank you so much indeed for walking through all aspects. Of course, it's a long debate. We could discuss it definitely for a long time. And I do see your questions here. I will give you some more time. Of course, there are questions ready. Before we start with your questions, keep them coming, of course. Questions, of course, there are plenty of those. There are some more specific ones. I would like you to see this one from Yana. Can you determine if an embryo is genetically abnormal without pgt testing? Where I'm from, it is not allowed, but the embryologist noted in her medical notes that the embryos have a high probability of genetic abnormalities. I am 38. Anything you can...
Right. I have to say, yes. Well, one thing is chromosomal abnormalities, and another different thing is genetical abnormalities. I mean, the chromosome in a pgt-a, we don't see the genes, we see the chromosomes. And definitely after a pgt-a, the genetist will say the number 1 has 46 chromosomes. It's normal. Number 2 is, as we said, chaotic, because there are abnormalities in the pair 2 and 21 and 22 and 14. And the other one is euploid, it's normal. And the other one, and number 4, has an abnormality in such in chromosome 14. Okay, so that is 100% sure what they're saying. The different thing is when the embryo may come with a genetic problem. For example, cystic fibrosis. A baby born with cystic fibrosis is a disease, it's a genetical disease where he or she has normal 46 chromosomes, but there is in a chromosome there is a little bit of the protein change and then cause the disease. So I don't know what that the patient says about the geneticist says. that was genetically normal or normal. But definitely, if we're talking pgt-a, pgt-m, as you said, because we have talked about this before, we are not looking at the chromosomes, we are looking at that particular disease. So if we're talking about pgt-a, the report says this is about embryo, it comes with abnormality, and it will be. Okay?
Okay.
They
All
come with
right.
other
Thank you.
things. And we
Thank
don't
you
know
for
why
the
only
clarification. Yeah.
56% of those
Right.
normal ones will lead to a pregnancy, and another 40 something will not give a positive pregnancy test. What's going on? Is it the biopsy which has damaged the embryo? Is because the embryo is far more things than just the chromosomes? That's a question to be resolved.
Mm. All right. Thank you. Next question, again, an interesting and quite common question. I've seen it many times. Do you think the embryo has
Yes,
its ability to repair
yes,
the abnormal
indeed.
cells?
That is what we call mosaicism. And
Mhm.
then nowadays, after when the blastocyst, when the embryo goes ahead, sometimes, sorry, I will return to the
Sure.
beginning. We do the biopsy, or the geneticists do the biopsy, and sometimes they report that this embryo is a mosaic. It means that they got some cells are normal and some cells are abnormal. And as the embryo goes ahead and gets more complicated, and may get rid of those abnormal ones and go ahead with the normal ones. That's why
Mhm.
when after a pgt-a we have 5 embryos, four euploid and one mosaic. The genetist will tell us, yes, leave it for the end, but you may transfer this particular one because those abnormal cells, this aneuploidy, is not compatible with life. So the most it can give is a miscarriage, but it cannot lead to, let's say, Down syndrome, Edward Turner, or other. But if these abnormal cells are compatible with life, nobody can bet whether the embryo is gonna divide the bad ones or the good ones. But in fact, it's something very common that not all cells in an embryo, in those mosaics, are exactly normal. That is a critics on the pgt-a, where we cannot study
Mhm.
all
Right.
cells of the trophoblast, just a large group. I don't remember if you are 6 or 12, and maybe you are just putting the needle in a place where all are normal, but then there is another corner where there are many abnormals, and vice versa. All right. But yes,
Okay.
the embryo may get rid of the bad ones, and that's something that we assume that are doing very often.
Okay. Thank you so much for that question. Definitely interesting. And we did some webinars on mosaicism. It's also a very complex and difficult subject, but so you can have a look at our previous events. You'll be able to find some more details on that as well. And I will go to the question from Yana again. She just put some more details here. I had 10 eggs fertilized, 9 made it to blastocyst stage, transferred 6 in 3 separate transfers, and had 2 chemical miscarriages. Is the issue equality? My embryos were not tested because it is not allowed where I'm from. I don't see the age here, but anything you can advise.
Right. I had transfer 6 in 3 separate transfer. So every time she had 2 embryos transfer, and had two biochemical miscarriages. Is the issue equality? We cannot say that. Look,
Mhm.
now we are facing a very common problem. So every week we have to talk about this with patients, and is the guidelines to failure of implantation. Failure of implantation, there are different definitions, but one of them is that a woman less than 38, 37 or less, who has had 3 embryos, 3 blastocysts of good quality, and she didn't get pregnant, or more than that age with a pgt-a, 3 euploid embryos, and she couldn't, she didn't get pregnant for one or other reason. Then that is a very complicated, okay, a very complicated issue, because then that caused a lot of anxiety in women and in doctors. Now, what I'm going to do with this woman? Okay, so the first thing is just to recommend a pgt-a, because the first thing is to see, are we transferring normal embryos or not, right? With euploids or not. But then it becomes there to send the patients to the hematologist to see if the heparin, it comes to the issue, if she needs heparin, aspirin, etc. Then the uterus is what part of this is taking the uterus. I mean, is hysteroscopy to see if there is a chronic endometritis, sorry, or dysmorphic uterus, or anything that it may prevent the uterus, the embryo to implant. And then the people who are very keen on hysteroscopy, they think that his subject is the most important one. And if the uterus is a bit abnormal, that's the reason why she's not getting pregnant. And then we publish that, and then women desperate reading internet, and they come saying, that's the reason why I can't get pregnant, because the uterus is in this way or the other way, or because I don't have heparin. And because the fact is that with hematologists, because it is another subject, failure of implantation, and I think that we talked about that in the past, then the failure of implantation, then we sent to the patient to the hematologist, and then they ask for a very large blood test. If there is something there, they will recommend heparin, and if not, they will recommend heparin as well. So in a very empirical and not scientific way. Then the last point is the hematologist. Doctor, we're not compatible, and because we are very different, our immunological system, and then my body is rejecting this baby. There are many, this subject has been criticized. There is nothing clear about it yet. So then that woman comes into a ward, come to a situation very stressful, but I would tell her, yes, so many embryos transfer. The first step is the next one, because thanks God, she's got a very good ovarian reserve, a large number of embryos to study. It would be the first step, pgt-a, and see what we have in between hands. If all of them are abnormal, then we said something goes wrong. Will my husband, will be me, we will study the husband, has not demonstrated that the ESRE, the European Society, is not approving yet the scientifically reasons to do fragmentation of DNA or fish chromosomal study of the spermatozoids, but we have these sort of things, karyotype, to see if it's the husband or not. So that's a very complicated subject when a woman reached to that point. But as I said, I want to repeat myself more, is the next step is to analyze the embryos. And we will go from it.
Thank you so much indeed. I think that was informative as well and helpful for you. Let me show you the next one, again, with some details. I'm 41, almost 42, with AMH of 7, 87, sorry,
PCOS.
80, yeah, due to PCOS, yeah. Over 3 egg retrievals, I have had 30 or more fertilized eggs each time only 2 blastoses, of which only 1 has been euploid. And first, frozen embryo transfer resulted in early miscarriage. Second, did not implant. I still have 1 euploid. I will soon transfer. If that fails, does it seem worth trying again? Or should I already consider donor eggs rather than spend the time on another attempt with my eggs?
Juliet.
Any advice here?
Well, okay. This is, well, translating from Spanish, we see that this is a sweet, a venom sweet, because you are a polycystic ovary and you are offering such a large number of eggs that is inviting you to do it. Because if you had an AMH of 0.5, that the question is there. Okay, don't do it anymore. Try to go to egg donation. Here, you say, well, if we are able to get 14, 15 eggs, then remember those statistics where we say that the 41, 1 out of 10 oocytes, it may come with being normal. So that invites you to repeat. I mean, 1, if you have done just 1, 41, 42, with a polycystic ovary, then it's very tough to say go to implantation. Okay. Again, I would do pgt-a. It's my opinion. Above all, when we have such a large number, probably of blastocysts, to discard those who are not definitely going to give a pregnancy and to give us some information. So, how to answer that? As I said, we have to think case by case. And the bad thing, you are 41 to 42. The good thing, you have an excellent ovary, which may give eggs to half of your city. I mean, that's so. Why not? We are not going to find a good embryo if we have such a large number of eggs.
There's a chance, right? High chance that it's possible.
Difficult situation, difficult to decide it.
Thank you so much. So it's always, of course, done individually. You definitely need to discuss it, right?
In the end,
give a proper answer. Case, that's always the case.
As in others, the decision will be Juliet who will take it. Yeah.
Thank you so much indeed for this. For yet another question. What kind of protocol do you use for very low AMH? Is natural modified or mini IVF preferred?
We don't use the mini IVF or natural cycles. I've never found any reason to do that. I mean, if a woman is able to give 4, why are we going to go with 1? That thing that was proposal that less is better has been demonstrated this is not true. I mean, and we saw that before. Remember, 4x at less than 35. If we have 4x, we have more chances to find the good one. So then to give more than 300 units of FSH per stimulation, it has been demonstrated it is not worth doing it. But I always use the stimulating cycle, not giving very high doses of hormones, but enough to obtain what she is able to give me. Of course, I've got cases because you work in this matter, you see all the span of possibilities of women with just 1 follicle. That she says, "Doctor, it doesn't matter. You have explained to me what my chances are, but I want to try." If she goes with 1, okay, so there is no point to give a lot of hormones, and just enough to grow that follicle properly. But I don't do the natural or mini FIV. Because, in fact, just I've been told that these mini FIV or natural cycles were invented in Holland. Okay, where it's said that a woman with good chances, I mean, it's less than 35 with good because she had probably the tubes blocked, etc., may go through 6 low-profile IVF. And then it's low cost, no need of anesthesia, no need of going to the hospital, and because of her probabilities after 6 with no FSH or very low, it's very cheap, etc., then a 30-something% will get pregnant after that period of time. And those who have not reached that, they will go to the standard one, right? So it's been designed for that very good prognostic woman, not for the others, right? So,
yeah. Thank you for explaining. Important to keeping that in mind as well, for sure. Okay, I have another question here. So my AMH is 0.14, but I have 6-9 follicles. However, only 1-2 of them is mature upon retrieval. What could be the cause?
Well, here the first thing is that AMH is not true. You see, it's being probably they took the blood, they left the blood for some time on the table, and then it reached the lab later, and it's been degraded because it cannot match 0.14 with 6 or 9 follicles because of what we explained before, right? So forget. That's why I said it's better the ultrasound scan rather than the AMH. AMH may give you an idea about things, but it has to be tested with recheck with ultrasound scan. Then 1 or 2 of them were mature. Then is when there are two reasons for that: the age of that woman and how she was treated. I mean, sometimes we have this sort of result. All specialists that work in reproduction, we have better and good results in our life. And when we face this low rate of maturity, then our option is to say, okay, next time we are going to try the trigger with two different hormones, with analogs and with beta-HCG, with Ovitrel, all right, or similar, right? To try to get better maturity. But sometimes that maturity or that lower number of embryos comes because, well, she may have 6 or 9, but she's 42. I don't know the age of this woman, all right?
Mm-hmm. Yeah.
So,
okay.
But the first thing that caught my attention is that that AMH doesn't match with the curve, okay?
Again, another thing to be careful about. Yeah, thank you so much. Very interesting indeed. And I will now go to the question. This is from a follow-up, actually. So in regards to mosaicism, I understand mosaic can self-correct. However, what about chaotic aneuploidies, multiple whole chromosome abnormal? In your 30 years, have you ever seen these kinds of blastocysts result in a normal live birth?
Not at all, because we are not entitled to transfer it. And because a chaotic or not a chaotic aneuploid embryo, just an embryo with proved by pgt-a, by geneticists, that the number 17 is has 3 chromosomes. That is not compatible with life, and we are not going to transfer it because it will not be ethical. So probably I've transferred many of this kind, but I didn't know because that woman didn't have a pgt-a. But having pgt-a, there is no way. I mean, this embryo goes to the trash because it's not going to give a pregnancy at all. All right.
Thank
Only
you for the clarification.
Some good cells that may multiply and win to the other group. But if has an aneuploidy, this will not be transferred, and consequently, we don't have that experience of repairing itself, that aneuploidy. Okay.
Yes, right. Okay. Thank you so much indeed again for that. And sorry, I will go to the next question. So it's let's have a look. Yeah, what is your opinion for the new fertile treatment being trailed for maturing oocytes in the lab, allowing for fewer days of simulation medications? What are the implications for older women attempting IVF? Do you think this will help or hurt outcomes compared to traditional means? Anything you can advise here?
This person, Juliet, is talking about the maturity of the eggs in the lab.
Yeah.
Need to obtain M1s, no M2s, no. So to perform the retrieval when the follicles are 14 millimeters, for example, or 13, instead of more than 17. Well, I don't have that experience. I will tell you that we do artificial in the lab maturity when just we have, in fact, last week we had one case where there were 6 mature ones and another 7 or 8 immatures. And those were left and they become M2 mature eggs in the end, and then were fertilized. And I think that of that group, she got 1 more embryo. So in the end, she's got 4 embryos, 3 coming from those mature eggs obtained, and 1 for the other group. So it's just something that we do when we obtain bad results, and we didn't expect these immature eggs to be obtained. Time ago, when we had the problem in the past, the problem of hyperstimulation of the ovaries, those polycystic ovaries, one of the options were to go to theater and to have the retrieval before they become very big and obtain 20 immature eggs and be mature in the lab. In Belgium, that big hospital in Belgium, in Brussels, that I was there for a weekend, just seeing what they were doing. They were keen on doing that that thing. But now, since we have the opportunity to avoid hyperstimulation of the ovaries, even the polycystic ovaries, I think that very few people are doing that. Okay, so I think that the artificial maturity in the lab is something that we do when we come across with something unexpected, when we come across with eggs which has come immature and we didn't expect that, and then we do something for them. But we are not planning to go for immature ones. There's no point, in my opinion.
Okay. All right. Thank you so much for the clarification. Now I will show you another longer question. Okay. So between ages 44, 46, I've done 10 retrievals, gotten 132 eggs, fertilized 92. In my first 5 cycles, I only got 3 aneuploid blastocysts. So we switched to fresh for day 3 transfers. I've done 4 fresh day 3 transfers of 6 at the time for a total of 24 with no success. I got 16 fertilized eggs in my last cycle. We allowed 10 to grow to blastocysts. I surprisingly got 4 blastocysts, did not do pgt-a testing. In the freezer, I have these 4 blastocysts, 6 day 3 embryos left, despite getting 12-20 eggs per retrieval. You can see AFC 8-12, AMH of 3.49
So
nanometer
polycystic
per
ovary,
kilograms.
are very good. Yeah.
My physician says it is time to give up after I transfer everything I have left when it comes to the embryos, given my track record despite good volume and my truly refractory case. Anything you can advise here?
Well, look, I just have to go back to the presentation and you will see what your chances are. And as I said before, my cut-off line for not treating any patient is 44. Once they are 43, 45, we say we are not going to do it because we have never seen a pregnancy. Then you've already had, if I read well, 10 IVF. I mean, you have gone to the theater 10 times to get, I think you've done enough for you. And after 132, I mean, this is far more enough to say I give up and I go for another way, which is egg donation. I mean, and this is telling what we said before about the number of eggs and what we said with another patient. This is a bad thing that you have such a good ovary in number, but age is age, and those eggs are not coming well. And I mean, you've done a lot. I mean, 10 IVF. It's time to change, and in my opinion, and to go for egg donation if you are prepared for that, and not to do that anymore. Of course, I think because there were a lot of information. I think that there are 4 embryos left. I think, no?
Yeah. So
of course, use it. Okay, if you want to analyze them to biopsy the embryos, that's okay. But use those. If you don't get pregnant, I will not go again for another retrieval.
Okay, exactly. Thank you so much for, I think it was clear as well. And we had one question before, how can you improve implantation in a woman over 40? Anything you can advise here?
Right. Implantation depends on the quality of the egg and the quality of the endometrium. So we have to improve implantation as we may do in any age. I mean, not in a woman more than 40, because a woman less than 40 may have a very bad endometrium, and a woman more than 40 may have a very nice endometrium. So analyzing, can I do something for the endometrium? Can I do something for the embryo? Treating you in one way, in the other way. So after 40, how can I improve it? Trying to get the best of the ovary, waiting for the month that woman in particular is coming with the best number of follicles to be used, and to be very careful and very delicate with the embryo, with a natural cycle if possible, and doing things well, preparing the endometrium. Then that's another subject, whether we should have platelets in the uterus or not in case of failure of implantation. That's a very complicated thing. But just to try to do things the best as possible. Even now, the probiotics, vitamin D, things like that, the European Society says that nothing has been proved about the chances of increases of doing something in fertility. Everything at the moment we are living a time in fertility with many things that were assumed that were nice, that were useful. Now it seems that probably they are not doing anything. So we have to keep all this in mind. Okay, it means that yeah.
Can you suggest, so what test do you do for endometrium? For
I've done many
implantation?
things. I've done in my career. I've done many things. Sometimes there were a period of time years ago where something was published in the States about filgrastim, which is a medication given to patients after a leukemia to recover the cells in the bone marrow. And then we used to put it inside the uterus because something was published that failure of implantation and they bad endometriums could get better and implant better. That it was demonstrated that it was not good. Then I've been using the test ERA, the biopsy to see the window of implantation. And then it's been published that after a large and very well done study done by the same people who were promoting that, saying that in 100, I think it was 800 patients study, the group not having had the ERA, the biopsy to check the window, got pregnancy, had a pregnancy in a higher rate than those who had the window scan to see whether to put the embryo on day 5 or day 6 or one day less or one day more. So in the end now, what we are doing is just ultrasound scan to check how nice it is or not, and then hysteroscopy and check whether there is an endometrial chronic endometriosis, chronic endometritis, or if there is any abnormality in the uterus that can be corrected. And then when we are very desperate, then sometimes we use the platelets. That probably in the future it will change because now we are just putting the platelets as it were an insemination, just moistening the endometrium probably to work as it works with the orthopedics in the joints. It may be injected inside by a hysteroscopy, injecting the platelets into the endometrium. At the moment, we're not doing that. So we do that. I've never seen after platelets. I have never seen the endometrium to increase the thickness of that endometrium. But if you put it and then she gets pregnant, that it was because of the platelets. And if not, even with the platelets, I couldn't get pregnant. That is why we carry on doing these sort of things, which has not been fully demonstrated. So at the moment, I'm just answering you, it's just a good vaginal ultrasound scan and hysteroscopy. These are the weapons that we use. Okay?
Perfect. Thank you so much. Important to note again. We will be slowly finishing. There are a few questions left. Let's have a look at this one. Age 39, not being successful with 2 euploids, embryo transfers, with immunologic treatment. Which would be the reason? What is the reason, and what do you recommend in this case?
If we could know that, I mean, that's that anxiety that you have is the same one that your doctor, your specialist has, but we don't know. That's the problem, and that's why the immunologic treatment exists, and that's why so many things done exist. And I say, okay, I think I've done this treatment, and it's been fine, and then everybody does it. Okay, so again, we know that every euploid, as I said before, any of these euploid embryos has a 56% chances of giving a pregnancy. So unfortunately, 2 embryos transfer, then you start investigating if you've done all the span available things about failure of implantation, although it has not been demonstrated, but you want to do everything possible, all right? But 2 embryos transfer, blastocyst transfer, euploid is within the possibility, the statistics. We say that one of the definitions of failure of implantations are 3 blastocyst euploid transfer with no pregnancy. Of course, we are not going to wait till the third one, and even after the first one, then we start doing these sort of things, going to the hematologist, to the immunologist, whoever may help the patients. And then that's why we have to be very strict with what is scientifically demonstrated or not, right? So what you may try, go for the third one if you have, or try again and do your best, and your doctors as well, trying to study your husband if possible, and then the endometrium, as we said, a hysteroscopy, and do everything that we know that it's available, and then cross your fingers, because unfortunately nowadays we don't know everything about, well, because in that case we were not have this we will haven't had this meeting today, because everything will be sorted. So
Exactly.
it's very hard to have 2 embryos transfer and not to be successful. You have to carry on trying and do what you are doing. Immunologist, hematologist, hysteroscopy, and these sort of things. And
Try to look for the reason, let's say. Yeah.
Exactly.
Okay. Thank you so much. I think that we can still have a look at the 2 more questions I see. Is there preferred stimulation drugs for women over 40 that help with the number of oocytes growing and maturing, or is it just dependent on the individual woman and her doctor?
Sorry, hold on. Is the preferred stimulation drugs for women? No, I mean, we have FSH, recombinant FSH, not recombinant FSH, and the other group of with LH factor. And well, over 40, it's always been said that the use of LH component after 35 is better after 40 as well. Is what we call in Spain the combo, FSH, recombinant FSH, and then the commercial names. For example, as Meriofert is the same in the whole Europe. Meriofert, Menopur, which has been these 2. HMG is the old one, all right, or the Pergoveris, which is Puregon FSH with LH. And I think that most of us agree that at this age it's good to have this LH component in the stimulation. That's all. That's everything. But okay.
Thank you so much indeed. And I think now we will go for the final question for today. So is implantation window specific to a woman relatively stable, or specific to an IVF cycle and changeable?
Well, that's the thing that it's been seen that in that study, those women who had the biopsy and the window study and change, they got pregnant less than the other group. So it seems that even the window may change. It's been demonstrated that window may change, and how important it is. So at the moment, we are not doing that. We are not taking care of the window implantation at all. We are, if a blastocyst is a 5 days blastocyst, we will give 5 days progesterone to be transferred, and that's it.
Okay.
That's everything I can say at the moment. All right.
It's changed, of course, yeah, because I guess ERA test was used before quite frequently.
One of the things that yes, a woman that it may be recommended in the past to be transferred the day 4 or 12 hours before. Then if they repeat it, they find that in another cycle it may be later. But it seems that is not so important. Probably that the embryo is going to find its place within a span of time sooner or later. It's not. Of course, if you're going to transfer a blastocyst with only 3 days of progesterone, probably the chances of being pregnant, it will decrease a lot. All right, but some hours up and down, probably it will not be so important at the moment as it seems being published. It's been published. Okay.
Okay. Thank you so much. I'm sure you have more and more questions, but we will be finishing for today. Remember that you can get in touch with the team directly, and I'm sure Dr. José Félix García will be happy to simply help you out. Remember, it's always best to get the consultation one face to face. I mean, also via Skype or Zooms, etc. It's always possible. So any doctor will need more information from you on your particular case. As you know, we always repeat that individual. It has to be individual case. You need to look at all the aspects, and of course, the advice has to be individual as well. All right. So thanks a lot. I do think it was a very interesting session. Any final words before we finish for today?
To me, I mean, final word.
No. If you anything.
No, that's it. This is no, I think that we said everything. I mean, it's quite complicated. It goes a lot of anxiety, but well, just say that the normal procedure is that a woman more than 40 comes and she's gonna fight for it. I mean, she's the first time. Very few will accept the egg donation and they want to try themselves, and that's normal. And I think it's what they should do. And then if they are, but they should be conscious of there is just a small percentage of success. Maybe they are going to be one of them, and they need to try themselves and see what happened. And if not, they will be in position to decide any other things. I'm going home and forget about this, and I'm going to egg donation. So it's normal, no matter how old the woman is, within certain number of age, less than 45, to try at least once and see what happened. So don't feel any shame yourself or anything, because that's the normal thing. But we cannot sell a very high percentage and to be, well, this is going to be very easy. And sometimes one is very tough to inform of all these things to women. Okay, that's it. All right.
Thank you so much. I believe that was a perfect ending for this today. Thank you. Thank you so much. It was lovely to have you. Thank you, everyone, for your questions. I do think it was really useful for you. Thank you for your comments. I see them. So thanks a lot for that. We will be back again tomorrow. We will talk about ICSI. So if this is a subject you would like to ask about and are interested in, you can join us. Ask Your Embryologist, our next event tomorrow at 7 p.m. London time. You can go to My IVF Fences and you will find all upcoming events right there. Thanks a lot, everyone. Take care. Dr. Garcia, I know we will have a chance to have another webinar possibly soon. So I'm really looking forward to it. Thank you so much, and take care. Have a lovely evening, everyone. See you. Bye.
Thank you. Bye, everyone.